my pleasure today to introduce Dr. Rachel Kadar. She's the Director of POCUS Education here for the Department of Anesthesiology, and she's really been instrumental in creating a well-rounded ultrasound curriculum for our residents, as well as starting to get our faculty involved in some of the ultrasound curriculum as well, which is wonderful. And I am looking forward to her talk on perioperative POCUS, a picture is worth 1,000 words.
Great, thank you so much for that introduction. Again, I'll be talking about perioperative POCUS, a picture is worth 1,000 words. I have no financial disclosures. The goal of today's talk is to demonstrate how point-of-care ultrasound, or POCUS, can change patient management. We'll start by defining POCUS and discussing its various applications. We'll walk through 4 clinical scenarios. Each will have some audience participation. We'll first ask a clinical question, then watch bedside ultrasound videos and revisit the same clinical question to see how additional knowledge from POCUS might change our answers. The take-home teaching points I want you to learn from today are to learn how to visually assess global left ventricular function, and to also introduce other diagnoses that we can make with bedside ultrasound. We'll end with some resources for further learning. POCUS, point of care ultrasound. It's oftentimes referred to, especially in anesthesia, as focused cardiovascular ultrasound, or GDE, goal-directed echo. But POCUS is much broader than that. The definition is a goal-directed bedside ultrasound examination performed by a healthcare provider to answer a specific diagnostic question or to guide the performance of a bedside procedure. As you'll note, POCUS is easy, quick, it answers a clinical question, it provides us more information, it is user dependent, but POCUS is not a complete exam and it's not a replacement for a formal exam. I always teach my residents, if you don't feel like you have a good enough image to obtain or answer the question, it's okay not to answer it. I think more information is always helpful. A leader in POCUS applications for anesthesiologists is Dr. Josh Zimmerman from the University of Utah. He gave grand rounds a while back, and he always says, if you don't look, you don't know. Supports that obtaining more information is always helpful. I know that this is a busy slide, and this is just to show the many examples of POCUS. POCUS includes various body systems: cardiac, lung, abdominal, vascular, soft tissue, musculoskeletal, gastric, ocular, and this is certainly not an all-inclusive list. I've highlighted in red the areas that the ASA has determined are important to the specialty of anesthesia: cardiac, lung, and gastric. Other specialties may focus on other areas. For example, trauma surgeons are often using the FAST exam when their trauma patients come in to look for free fluid, often assumed to be blood in their trauma patients. I'm often using soft tissue ultrasound in the ED to differentiate an abscess from cellulitis. I've often seen neurointensivists using ocular ultrasound to evaluate elevated intracranial pressure. In addition, POCUS can be used to develop a differential. For example, if a patient's in shock, they're dyspneic, chest pain, abdominal pain, or determine fluid status. I put these other ones in red because they are other examples of ways that anesthesia is currently using ultrasound. POCUS is here to stay. This is a summary from the New England Journal of Medicine from 2011, showing how every specialty is utilizing ultrasound. For example, ophthalmology is using it for corneal and retinal assessment, rheumatology for monitoring of synovitis. I'd like to note that this is from 10 years ago, and this is rapidly expanding. For example, anesthesia is listed at the top, and you can see that you're already using ultrasound for much more than vascular access and regional anesthesia. One example of how anesthesia is expanding in its ultrasound use is in the evaluation of hemodynamically unstable patients. Here's one protocol that can be used, and this is the one that I teach the residents, the Rush protocol seen here. Of note, there are many different protocols available. This is certainly not the only one. As you can see, this Rush protocol includes cardiac views, 1, 2, and 3. It includes right upper quadrant and left upper quadrant views to look at the abdomen, and you also slide up and look at the lower thorax. It includes pelvic views down here, abdominal aorta, and lung views up here. Now that I've hopefully convinced you that POCUS is essential to modern day medicine, we're going to go through some real life cases. So here's our first polling question. So this is your first case. 34-year-old female, G1P1 status post cesarean delivery, EBL 1500. She's gotten 2.5 liters of crystalloid and has finished her oxytocin. You're called to the PACU to evaluate for persistent hypotension. The resident notes a small amount of vaginal blood. What do? A, give a fluid bolus. B, give blood. C, start vasopressor inotrope support. Or D, give methylorgonavine. A couple seconds too. So you guys should be able to see those results. As you can see, an overwhelmingly high number give a fluid bolus. Now you obtain this bedside ultrasound view. This is a peristernal long axis view. It's along the left sternal border, indicator towards the right shoulder. The structures we're looking at here are the left ventricle, mitral valve, left atrium, LVOT, ascending aorta, and RVOT. Then you move on in this patient to obtain a peristernal short axis view. So you rotate the probe 90 degrees clockwise, so the indicator is now at the left shoulder. The structures that you're looking at here are the circular left ventricle and a crest-centric right ventricle. And again, this is the image that you obtain on this patient. Now that you have ultrasound imaging, how might you change your answer? I'm going to pull up another poll. Great. So let's talk about some of those images. So first we'll talk about global left ventricular function analysis. Research shows that a visually estimated global left ventricular ejection fraction is just as good as a calculated one, especially in a trained person. And this is the recommended way for assessing left ventricular function in POCUS. When I do this, there are 4 questions that I ask myself. Those questions are: 1, does the chamber size get smaller? 2, do the walls thicken? 3, does the mitral valve touch the septum? And 4, does that mitral valve annulus move? More specifically, I'm looking at 1, endocardial excursion. So does that endocardium move towards the center of the chamber in systole? So if I put my cursor right here, are those walls coming in towards my cursor? 2 is going to be myocardial thickening. The myocardium should increase by about 40% in systole. So I'm taking my eyes and I'm going around the myocardium and looking at each area to see that it actually thickens. 3 is going to be EPSS, or E-point septal separation. And that's that anterior leaflet of the mitral valve. Does it appear to reach up and touch the septum? Because in a good ejection fraction, it should reach up and almost touch that septum. And then 4 is going to be MAPSI, or mitral annular plane systolic excursion. And I just, again, visually eyeball it and look, does this lateral annulus of the mitral valve kind of appear to reach up and move towards the apex? And this kind of represents the longitudinal fibers that contribute to contraction. We're going to take a look at some more videos. First one is endocardial excursion and myocardial thickening. So I want you to watch both videos and ask yourself, does the chamber size get smaller and do the walls thicken? And estimate what you would call each ejection fraction. So there's our video on the left. And then here on the right. So the one on the left is a normal ejection fraction. The one on the right is severely reduced. If you look at the one on the left, I can put my cursor right here in the center. The walls come in towards the center. They're thickening. If you look at the one on the left, They're already very thick. They're certainly not thickening much with contraction, and they're not coming in towards my cursor right here. Next, we'll talk about EPSS, E-point septal separation. Does that anterior leaflet of the mitral valve appear to reach up and touch the septum? The definition of EPSS is the minimum distance between that anterior leaflet of the mitral valve and the septum. So an increased EPSS correlates with a decreased ejection fraction. So if you want to look at it, sometimes I just look at this qualitatively. So I'm just looking at this anterior leaflet, and if you have good cardiac function, it should reach up and kind of appear to almost touch the septum. You can also do it quantitatively if you'd like. You can put an M mode through the anterior leaflet. M mode is motion mode. So this plots this as motion over time. So for example, this black or anechoic area here correlates with this black anechoic area here. And again, we're looking at the motion of the mitral valve. So here's that mitral valve moving up. This is the E wave and the A wave. E wave is an early diastole. It's reaching up, and this represents the septum right here. So again, this is in the peristernal long axis view. We put M mode over the anterior leaflet of the mitral valve, and we can measure that distance. So here you can see we've measured the distance in both of these. Again, just visually, I can see that this is a very small distance. So this is a normal ejection fraction. This is a very large distance, so it's not likely to be a normal ejection fraction. If we want to know, those numbers are 0.54 centimeters for here and about 2.5 centimeters in this one. In the literature, when looking at numbers, there's a lot of different cutoffs that are used. The one I tend to teach the residents, because it's easy to remember, is that if it's greater than 1 centimeter, the ejection fraction is likely less than 30%. Some people do use 1.8 as a cutoff to being less than 30%. But either way, you can kind of get an idea of whether cardiogenic shock is the etiology of your shock. Remember that there are falsely elevated EPSSs in mitral valve disorders, aortic regurgitation, and LV dilation. So now we'll take a look at a couple of videos and we'll ask ourselves, does the anterior leaflet of the mitral valve appear to reach up and touch the septum? And then in the second video. You can see on the left, it's severely reduced ejection fraction, and on the right, a normal ejection fraction. So again, to look at those, here's that anterior leaflet of the mitral valve. Here's that septum. It is certainly not anywhere close to reaching up and touching that septum. Whereas in this one, you can see it really reaches up and appears to touch that septum. Next, we'll talk about mitral annular plain systolic excursion or MAPSE. And that question is going to be, does this lateral annulus of the mitral valve move up towards the apex? So let's take a look at both of these videos and again, estimate what you think that the ejection fraction is. I apologize. Sorry about that. We'll move forward, oh, there we go, and say that the one on the left is a normal ejection fraction and the one on the right is severely reduced. So if you see right here, this lateral annulus is not reaching up and moving towards that septum. So you have a severely reduced ejection fraction. Whereas in this one, if I put my cursor right here, you can see that that lateral annulus is clearly moving up towards that apex. So back to our case. Again, these are the videos, so we can assess. Again, this has an increased EPSS, it correlates with a poor ejection fraction. We don't see good endocardial excursion. Our myocardium is not thickening the way we would expect. Same thing here, if I put my cursor in the middle, those walls are not moving in towards the center. So our correct answer after we got our bedside ultrasound was C, start vasopressor or inotrope support. And the diagnosis is peripartum cardiomyopathy. We would start dobutamine. You can add norepinephrine if needed. You can titrate up the dobutamine and consider diuresis for volume overload. Now we have our next case. So this is a 58-year-old female, and this is a real case I had at a small community hospital. The anesthesiologist called me in to help. 58-year-old female with a trimalleolar fracture. You were in the OR for an ORIF. Upon emergence from anesthesia, the patient becomes hypotensive, blood pressure 60/40, and hypoxemic, O2 sats 82%. The patient's otherwise healthy and sustained an ankle fracture while biking in South America last week. What do you do in this scenario? Call cardiology for a stat consult for likely intraoperative MI. Place an arterial line and send an ABG with hemoglobin. C, listen for bilateral breath sounds and call for a chest x-ray. Or D, give TPA, tissue plasminogen activator. Okay, I think that sounds like certainly the most reasonable first step in this scenario. So now you obtained this ultrasound. So here's your probe. This is an apical 4-chamber view with the indicator towards the bed or at the 3 o'clock position, just underneath and lateral to the nipple. You're kind of looking up at the heart from underneath, and these are the structures that you're seeing: a left ventricle, left atrium, right atrium. So this is the ultrasound. So now that you have that ultrasound imaging, how might that change your answer? Launch another poll. All right, I see we are split a little bit. Let's talk about those images. So now we're going to talk about right ventricular assessment. So when I look at the right ventricle, there are 3 things I focus on: size, the interventricular septum, and function, or TAPSE. When I do size, this is best done in the apical 4-chamber view. And when I look at the size of the right ventricle, I'm really comparing it to the left ventricle. So it's important that I get a good apical 4-chamber view to appropriately assess the size. For the interventricular septum, I'm looking at this in the peristernal short axis view. And for function, if I want to calculate the TAPSE, the apical 4-chamber view is the best, but I can also visually do it in the subcostal 4-chamber. So let's talk first about size. Again, we said it's best to evaluate in the apical 4-chamber, and there are 3 categories when we talk about right ventricular size: normal, moderately dilated, and severe. So normally the RV should be less than 2/3 the size of the LV. Moderate dilation, the RV is greater than 2/3 the size of the LV, and severe dilation, RV is greater than the LV. I always tell the residents from a POCUS standpoint of view, if the RV and the LV are the same size, that's bad. If the RV is bigger, that's really bad. Just make sure your probe isn't swapped. The other thing is that the RV should be triangular shaped. As you have acute RV failure, that right ventricle will start to dilate and kind of balloon out. In addition, the dominant chamber at the apex should be the left ventricle. So here's some pictures. I want you to take a second to look at each picture and think in your mind which category you would put each right ventricle in. So here you can see the right ventricle is normal. It's 2/3 the size of the left ventricle. It's triangular shaped. And the dominant chamber at the apex is the left ventricle. Down here with moderate dilation, they're both about the same size. As you can see, this right ventricle is not really triangular shaped anymore. It started to kind of balloon out and become almost circular. And the apex is almost split. Here, in this one where it's severely dilated, that right ventricle is actually bigger than the left ventricle. It's ballooning out, and it's also almost starting to take over that apex. you'd obviously want to make sure that your probe is not switched. Ways that you can tell is that the septal leaflet of the tricuspid valve is going to be higher than the septal leaflet of the mitral valve. So that confirms that this is the tricuspid valve and that this is the right ventricle. In addition, in the right ventricle, you'll have the moderator band, which sometimes you can see going across. So if you weren't the one taking your own images, sometimes those are two tips that can help you feel confident that the probe is not swapped. A word of caution when you're looking at right ventricular assessment. Here is an apical view, and here are the different cuts that you can see here in this picture. So as you notice, changing your angle can give you the same left ventricular size with 3 different right ventricular sizes. And so if you're over here at 3, your right ventricle may look normal, whereas 1 would be the appropriate angle to actually look at that right ventricle. And so it might actually be dilated and you might miss it. So it's very important to rotate the probe, and this is just a teeny tiny little adjustment to obtain that largest right ventricular size. So we want to avoid underestimating by rotating until that maximum plane, underestimating the size of the right ventricle. We want to also avoid overestimation, although it's much more likely that you would underestimate the size of the right ventricle than overestimate it. But if that RV is significantly foreshortened, sometimes you can overestimate it. When we talk about interventricular septum assessment, this is in that parasternal short axis view. This is your left ventricle right here, and this is your right ventricle. So normally that left ventricle should be a circle, and that right ventricle should be that crescent shaped coming around. But as pressure in the right ventricle increases, that septum will flatten, and this left ventricle will become D-shaped. The teaching is that in volume overload, you'll have that flattening in diastole, but as you start to have pressure overload, you'll have flattening in both diastole and systole. So here you can see that the septum is still flattened in systole, suggesting a very high right ventricular pressure. It's also important to note that if your parasternal short axis view is very low on the chest, you might see an inappropriate D sign. By inappropriate, I mean it's not pathologic. This septum may start to be flattened just because of your angle. So I just always warn or caution people to not say, oh, it's the D sign, it's definitely a PE. Make sure that you're appropriately, have an appropriate angle to evaluate for the D sign. The last right ventricular assessment we'll talk about is TAPSE, or tricuspid annular plane systolic excursion. This is great to learn about RV function. Again, this is essentially just the opposite of MAPSE. Although MAPSE is more of a POCUS view that you just qualify by looking at your eyes. You don't necessarily, I don't usually measurement, and it's not something that's in the echo reports. It's something that's more of a POCUS thing. Whereas TAPSE is used by cardiologists, it is in the echo reports. So for TAPSE, you want to put M mode through the lateral annulus of the tricuspid valve. Again, this is motion over time, and you want to make sure that this M mode goes through the apex of the right ventricle. And what you're measuring is that longitudinal displacement of the annulus at peak systole. And so this movement right here correlates to that movement of the annulus, kind of up and down towards the apex. And so here would be that measurement, that peak to trough, essentially, that TAPSE. And I recommend the residents commit this to memory that a normal TAPSE is greater than 17 millimeters or 1.7 centimeters. You can't measure this in the subcostal 4-chamber view, but if for some reason you don't have a good apical 4-chamber view, you can visually estimate it. Oftentimes you can get a good view of that right ventricle in the subcostal, and you can at least visually estimate TAPSE. It's important to note that while TAPSE can be a great way to look at right ventricular function, you can still have right ventricular failure with a normal TAPSE. And here's an example right here. So this, you can see, we talked about right ventricular size. This right ventricle is larger than the left. It's not really triangular shaped, it's ballooned out, and it's starting to take over the apex. So if I put my cursor right here, though, we do see that there's a normal TAPSE because that is moving. However, if we look at our right ventricular free wall, we can assess RV function the same way we do LV function. Are the walls thickening? Is the chamber size getting smaller? And we can see here that clearly we have RV free wall akinesis. It's not moving. We're in RV failure. And so this is an example of the McConnell sign, where you essentially have free wall akinesis. So that free wall is not moving, but normal motion at the apex. And the thought is that that right ventricular apex is really being pulled by the left ventricle, by a hyperdynamic left ventricle. and this is specific for a pulmonary embolism. So back to our case. I know this is a very grainy POCUS image, and I also don't know how well the images are going through, but this is apical 4. This is a left ventricle, left atrium, right atrium. You can see that this right ventricle is larger than the left ventricle. Maybe you can't see the free wall extremely well, but we can tell that we have significant RV failure. So the answer then would be you have a massive TPA and you would give, or a massive PE, you would give TPA. Massive PE is defined as a systolic blood pressure of less than 90 for 15 minutes or requiring inotropic support. You would give TPA. You could do the full dose, alteplase 100 milligrams over 2 hours, or you could do half dose, the 50 milligrams over 2 hours. And a reminder that the cardiac arrest dose is going to be 50 milligrams IV push over 60 seconds. And the recommended time that you continue CPR after that is 30 to 60 minutes, and you consider redosing. So case 3, again, another real case I had at a small community hospital. This is a 39-year-old female with a history of lupus. The patient was planning to be discharged today. She's getting ready to leave. She states she feels short of breath and has chest pain that feels like a heaviness. The patient then collapses, no pulse is found, and CPR is initiated. There's return of spontaneous circulation after 1 round of CPR and 1 milligram of epinephrine. She's intubated and brought to the ICU. The following EKG is promptly obtained. And this is the EKG. This is her actual EKG. And you can see that there's some abnormal ST changes in 2, 3, and AVF. But what's most interesting is that this EKG was read as an acute MI. So 39-year-old female with a history of lupus, status post-cardiac arrest. And the EKG is read as an MI. So what do you do in this scenario with the information that you have? All right, so some people are clearly catching on as to where this is going. But I will say that my initial thought, of course, was to grab the ultrasound, but also to think, I don't really think this is a STEMI, but do I need to be activating the cath lab, especially with that read, or at least talking to cardiology? But then I go to get my ultrasound. And this is a subcostal 4-chamber view. So your probe is down here below the xiphoid process, indicator towards the patient's left, with ultrasound beam looking up at the heart from below. These are the structures that you'll see: the right ventricle, right atrium, left atrium. It's essentially an apical 4-chamber kind of turned on its side. And you'll see the liver here at the top of the screen. And getting that liver at the top of the screen helps give you that a good acoustic window to be able to see. And so this is, again, the ultrasound that we saw. So now that you have that information, let's see how our answers might change. Uh-oh. Sorry, let me end this polling. That one for some reason. Here we go. Now let's try again. Thank you for the kind people who answered anyway. All right, so we can see now that the next step would be to prepare for pericardiocentesis. So we'll just talk briefly about pericardial effusion and tamponade. While you can see this in other views, it really is best seen in the subcostal four-chamber view. And really evaluating for tamponade especially is best done, I believe, in that four-chamber view. Pericardial effusion is defined as fluid in the pericardial space. Technically, it's anything greater than 50 cc's. The etiologies include malignancy, uremia, trauma, infection, and rheumatologic disease. And our patient with lupus was probably rheumatologic disease. When you measure it, you want to measure at that largest point in diastole. And again, I think 1 centimeter is a nice number, easy number to remember. So small is less than 1 centimeter and moderate to large is greater. It's important to note that an effusion might not be circumferential in post-cardiac surgery patients. So if tamponade is on your differential and you do a transthoracic echo and you do not see a pericardial effusion, you may still need to do a transesophageal echo to look for that information because it might not be seen on the anterior part of the chest. In addition, tamponade is going to be when you have a pericardial effusion that's to the point where you have impaired cardiac output. So essentially, once you get to that point where the pressure in the pericardium is greater than the right ventricular filling pressure, then you're going to start to have impaired cardiac output, tamponade physiology, and a more urgent intervention is needed. What you'll see on ultrasound is what we call right ventricular diastolic inversion, and that just means that in diastole, that free wall is going to be indented by fluid. You'll also see a large and plethoric IVC that does not collapse. But wait, is this truly tamponade? So I'd like you to take a look at both videos and think to yourself if you think that it is tamponade or not. They both have very large pericardial effusions. So that one on the left, while the pericardial effusion is large, it's actually not tamponade, whereas the one on the right is. If you look here, in diastole, that right ventricle is still able to fill. That right ventricular free wall is still expanding out. But here you can see that this is not filling. I also kind of call this the funny wiggle. I get nervous when I start to see the funny wiggle of the right ventricular free wall, because you can see that their pressure is being pushed on that RV free wall and preventing its ability to expand. So back to our case. Again, this is what we saw. Tamponade. Clearly, you can see that funny wiggle, and you can see that this is not expanding. Of course, when I talk about tamponade versus no tamponade, I want to note that in all of the shock protocols, if you see a large pericardial effusion, I don't think it's necessarily appropriate to say, oh, I don't think it's tamponade, I'm not going to worry about it. I would still, with a large pericardial effusion, get cardiology involved to just determine. But it's also helpful to know when you call them to say, hey, I don't think it's tamponade, but this patient's in shock, and I need your help to know for sure. So now what would we do? We would prepare for a periocardiocentesis. The diagnosis is cardiac tamponade. You want to give IV fluids to increase that right ventricular volume and maintain preload. Pericardiocentesis or pericardial window is the definitive treatment. And in the setting of cardiac arrest, pericardiocentesis must be completed emergently at the bedside. So I was the only physician at this small hospital on a Sunday and had to go forward with a pericardiocentesis because she continued to code. Here is the imaging or the various ways that you can attempt a pericardiocentesis. You can do it peristernally from this side or here. Subxiphoid is the most recommended, and you can place the probe across the chest in that peristernal view to watch as your needle comes in. So a needle was inserted from a pericardiocentesis kit into the pericardial space from the subxiphoid. It's helpful to note that pericardial fluid does not clot. In a pericardial effusion that's so large that you're the one doing the pericardiocentesis, it's kind of hard to miss the fluid, but it's also helpful to feel reassured when you know that that fluid is not clotting, that you're in the right space. You can also use a needle or catheter from a triple lumen catheter kit. So you don't need a pericardiocentesis kit. You just take the triple lumen, and then once you take that syringe off, you can just get a larger syringe and just keep pulling off fluid until you get some hemodynamic improvement. And this was all the fluid that was quickly taken off of her heart, and we had return of spontaneous circulation very quickly. So this is our last and final case. We have a 52-year-old obese female status post an open abdominal hysterectomy for endometrial cancer. EBL is 400. She received 2 liters of crystalloid in the OR, was stable throughout her case. You are called to the PACU to evaluate her for hypotension. Her blood pressure is 85/40 and her heart rate is 100. What do you do? A, return to the OR for exploration. B, give a fluid bolus. C, check a CBC and call for blood. Or D, obtain an EKG. I think these are certainly the best answers that we would be doing, probably giving a fluid bolus initially and or checking a CBC and calling for blood. And now you go to obtain these views. So this is a subcostal inferior vena cava view. So your indicator has been rotated from that xiphoid 4-chamber view 90 degrees counterclockwise so that your indicator is now towards the head. And we're looking at that IVC and long axis view. So here's your IVC dumping into your right atrium, and you see the left hepatic vein. This is in cardiac mode. Sometimes you will see it swapped like this, where the heart is on the opposite side and it's in abdominal probe mode. But either way, you'll see a horizontal IVC. And then you move on to do a pelvic ultrasound. So this is a sagittal view with the indicator towards the patient head. And we're seeing that bladder right here looks kind of triangular shaped. So now that we have those views, let's see if that changes our answers. What do? A, return to the OR for exploration. B, give a fluid bolus. C, check a CBC and call for blood. Or D, obtain an EKG. Great, so now we have some new answers that we didn't include on the first one. So let's talk about some of our imaging. So this is what we saw. This is the IVC view. Here's the inferior vena cava going into the right atrium, and this is the left hepatic vein coming down. Again, this is where that probe is with the indicator towards the patient's head, looking at that IVC longitudinally. Things we want to see on the IVC to know we're looking at the IVC is we want to see it connecting to the right atrium, and we want to see this left hepatic vein coming down. If we see those two things, we can know that we're looking at the IVC and not the aorta. Note that the IVC may pulsate, especially because it can be right next to the aorta. So looking at pulsation, I think, is less helpful. The other thing is when you have an IVC, you'll see liver on both sides. The left hepatic vein coming down can help ensure that you're not looking at the right hepatic vein and thinking it's the IVC, which could potentially happen in a cirrhotic patient who might have a dilated dilated hepatic veins. So when we talk about IVC, there are actually two distinct uses of IVC in ultrasound, and these are the estimation of central venous pressure, or CVP, and the prediction of fluid responsiveness in a hypotensive patient. So if you note, for estimation of CVP, this is a measurement that the ultrasonographers do when they do an echo, and they put this on their echo report. And this method of evaluating CVP is in spontaneously breathing patients, because that's what the literature supports. And they basically use an algorithm where they take into account the size of the IVC and the respiratory variation. So does it collapse when the patient does a sniff test when they breathe in? And it assigns a right atrial pressure of 3, 8, or 15. So for example, if the IVC is small, less than 2.1, and it does collapse with inspiration, they assign a right atrial pressure of 3. If the IVC is large and doesn't collapse with inspiration, they assign a right atrial pressure of 15. If it's in the middle, if it's large but does collapse, or if it's small but doesn't collapse, then they get a right atrial pressure of 8. So you'll notice on all the echo reports, right atrial pressure is either 3, 8, or 15. You never see 7 or 10. This is slightly different, although sometimes it does correlate with the prediction of fluid responsiveness in a hypotensive patient. So when we look at that, there's a different set of literature. And the take-home point that I think is the most important thing to remember is that an IVC diameter of less than 1.5, these patients will be fluid responsive. If you want to get more specific and separate out mechanically versus spontaneously breathing patients, then we can calculate some calculations such as IVC distensibility and IVC collapsibility. This is a nice point of care fluid resuscitation guide. So I just want to point out here, the normal IVC, they consider 1.5 to 2.5 to be the normal range. So that's what I teach the residents. If it's underfilled, less than 1.5, you can fluid resuscitate. All literature would suggest that in both an intubated and a spontaneously breathing patient, that hypotensive patient will be fluid responsive. On the other end, if the IVC is distended greater than 2.5 and it's non-varying, you can fluid restrict. Maybe it's time to move on to your vasoactive agents. But it's also important to note that this patient could still be fluid responsive in certain scenarios, particularly tamponade, pulmonary hypertension. If you're in this normal range, this is where we might start talking about IVC collapsibility versus distensibility. So this breaks this out into intubated versus non-intubated patients. So if you're intubated, they recommend that if you're passively triggering, or if you're passively ventilated, so you're not triggering the vent, that you go on to do IVC distensibility. However, if you're not intubated, they actually didn't feel like the literature was strong enough for IVC collapsibility, and so they went on to suggest a lung ultrasound to kind of decide. And if there were B lines, which is consistent with pulmonary edema, they would recommend fluid restricting. But if there's A lines, go ahead and fluid test and see if the patient responds. So this is our pelvic ultrasound. When we do pelvic, we have two views, the sagittal view with the indicator towards the head and the transverse view with the indicator towards the patient's right. And these are the different views that you're going to see. In the sagittal view, your bladder will be kind of triangular. And in the female patient, you'll see the uterus and the uterine stripe. And back here is what's called the pouch of Douglas. So if you're looking for free fluid, it will first collect here in the pouch of Douglas. If you have a significant amount of fluid, it may start to come around over here and you might see it between the uterus and the bladder. But if you're initially looking for free fluid, which we assume in a trauma patient is blood, you might assume in your post-op patient is blood, we want to start looking here in this pouch of Douglas. Here in your transverse view, that bladder is going to look a little bit more like a trapezoid. So take a look at both of these pictures and assess whether you think you see free fluid in them. So here, this one on the left, this is no free fluid, and here there is free fluid. So here is that sagittal view. That bladder here is triangular shaped. There's the uterus, and right here would be that pouch of Douglas where we're looking for anechoic or black on the ultrasound, which would suggest free fluid. And here, you can see right here, lateral to the bladder, and even a little bit coming in here through the video, a little bit of anechoic or black to show that there is free fluid back here behind the bladder. So just to review, when you talk about a FAST or focused assessment with sonography and trauma, again, we said it includes A, B, C, and D, these four views. D we've just talked about, but just to briefly touch on B and C, B is going to be that right upper quadrant, which is Morrison's pouch, is the most commonly placed looked at in the right upper quadrant, and that's because that's where fluid is most likely to go in the right upper quadrant. That's also known as the hepatorenal recess. So that's that area between the liver and the kidney. You also want to make sure you scan out to see that liver tip. So looking all the way to the edge of the liver, and that's your right pericolic gutter. On the left, you have one other space you want to look at, and that's the subphrenic space. So that's between the spleen and the diaphragm. And that's because while on the right, fluid is most likely to go into Morrison's pouch, on the left, it's most likely to go in that subphrenic space. So again, you would look for black, which would be anechoic or dark on the ultrasound, which would represent free fluid. And you'd look first in that subphrenic space, and then you would still look in the equivalent of Morrison's pouch, which is the splenorenal recess, an area between the spleen and the kidney. And then you'd also want to fan out to look at that spleen tip for the left pericolic gutter. So back to our case. Again, this is a pelvic view. This is a sagittal view. So that bladder is triangular. And you can see all here there's a significant amount of free fluid, this black anechoic that comes all the way up here, and maybe even a little bit of clotted blood up here, which would suggest that this is blood. And then here on the right, this is an IVC ultrasound. It's swapped, so your heart is over here, but here you can see this IVC is small and collapsing. I always recommend that the residents measure it, because sometimes when you change your depth, you might say, oh, that looks small, and it's actually big, or vice versa. But we can even just looking at this, see that it's very small, it's collapsing. You can see the left hepatic vein coming down here. You see liver on both sides. You see it going into the right atrium. So we feel pretty confident that that's the IVC. It's small and collapsing, definitely less than 1.5 centimeters. So this patient needs volume resuscitation. So while I know you would also probably give a fluid bolus and check a CBC and call for blood, the new answer that we wouldn't have otherwise chosen would be to return to the OR for exploration, now that we have our ultrasound information. And the diagnosis was postoperative hemorrhage. The patient was taken back to the OR for exploration and control of the bleeding. Again, a real case from one of my colleagues. 3 liters of blood was found in her abdomen. Some of my favorite resources for POCUS ultrasound, Josh Zimmerman, again, we talked about him at the beginning. He's the vice chair of the Division of Perioperative Echo. He has an amazing echo lecture series that's all online and free. And he's starting to expand to also include lung and gastric ultrasound. The POCUS Atlas is a heavily used emergency medicine website. It has a lot of evidence-based POCUS also, kind of reviewing what's the literature behind what's helpful, what's not, why we do what we do. And then 5-Minute Sono is a wonderful website that has just 5-minute clips on various ultrasound things. So if you don't have much time and you just want to take 5 minutes to learn a little bit more about ultrasound, I recommend you go to 5-Minute Sono and pick a video. Just a brief mention of the ASA Diagnostic POCUS Certificate Program. We already have a group of people signed up for this year, and I'm sure it will be a rolling process if people want to enroll later. It includes some POCUS training, some image interpretation and image acquisition, and I'll be here to serve as a mentor and help you go through your images and progress along throughout the program. Special thanks to all of these wonderful physicians who helped me with this presentation. I really appreciate it. And then questions.
Thanks, Rachel. This is Jimmy. Can you hear me?
Yes.
Yeah, that was awesome. You know, me having come back after so many years, I was just blown away by how much the residents seem to know about echo. And I think a lot of it's just from the material you teach as well, but it's just becoming so much more common now. Do you think that it's just going to become some sort of requirement as well in terms, I don't think there's an official amount of echo you need to do to complete residency, but I went to ASRA meeting where for regional anesthesia, and one of they're talking about POCUS becoming so much more prevalent now that it may eventually just become a part of the certification or the process of completing residency as well. Do you see that?
Yes, I definitely do. In emergency medicine, it is already part of our ACGME milestones. We have to complete and interpret so many ultrasounds in order to graduate emergency medicine residency. So I think that has been in place for a long time. And I think as it continues to expand, it will next become part of anesthesia, internal medicine.
Yeah.
And it's also being incorporated now in medical school curriculum more and more.
Yeah, yeah. I definitely.
For Jimmy and Rachel, sorry, this is the way I care meeting. It
Hi.
is now a part of our milestone evaluation.
Okay.
To actually document, and it's not just it has to be done at the end. We have to document their progress towards POCUS goals throughout training.
Gotcha. Yeah, I think that's awesome, and I think it's huge improvement. I came from the era when we did put lines in blindly most of the time, but having put in all of my lines lately with ultrasound, I don't see myself ever going back to doing it blindly now a lot of the time.
Hi, this is Chris Stock. Also at the American Board of Anesthesiology, when you go to take your advanced exam, 3 of the 4 OSCEs include ultrasound use for vascular access, for regional anesthesia, and for cardiac imaging.
Yeah, makes total sense. Awesome. Thanks, Rachel.
Thank you.
We have a couple more minutes for questions if anybody has any other questions. I know this was a very visually heavy grand rounds and it was wonderful, but in this virtual world, I know we're doing other things as we are listening. So if anyone would like access to this presentation, please email me or Elaine Wong, and we will try and get access to the recording for you.
Hi, Rachel, it's Luann again. This was so helpful. A lot of key things that you covered. I'm wondering if you would be interested in working, if you haven't already done some of these, working with maybe one of the residents on a quality improvement project where we could have some quick reference guides to put on the anesthesia machines, especially some of those more technical points where you do have to remember some numbers like the IVC, diameter, some of the EF evaluations. That might be a good use of some resources where we could put quick guides on the anesthesia machines, or in all of our other care provider areas, the PACU ultrasound machine or things like that.
Yeah, that's a great idea. I'm actually working with one of the residents on a PACU quick guide, and we've created it and we're using it kind of every other month right now and doing questionnaires to kind of assess if it's helpful. But I think that would be a great idea to kind of expand it and then see if we want to edit it for the general anesthesia machines or if it's a good all-inclusive one to use for all of them. So thank you.
Yeah, I think there's so many faculty with butterfly probes. It might be helpful to have quick guides, not just attached to the ultrasound machines, but more ubiquitous throughout the academic care area. So this was really an excellent presentation. Thank you so much.
Great, thank you.
Hi, Rachel. This is Dan Fagan. Can you hear
me? Yeah, it's like a little quiet. So.
Sorry. So one question I have, when you show some of your images and obtaining those images, the patient has to be in a specific position. Many times I feel like obviously in the OR, we don't have that luxury of, when we're trying to do something that's occurring, when something like this is occurring during a case, you can't obviously turn the patient maybe lateral to obtain that optimal image. Do you feel that, if you had a patient who was supine, and are you able to obtain the images still to a satisfactory level that you can make a diagnosis, or do you need to kind of proceed a little bit more cautiously trying to make that diagnosis since your image is going to not be optimal?
That is a great question. So as you mentioned, in emergency medicine and especially ICU, we don't really have the ability to turn them in the left lateral, which all the guides say to do. So when I practice with the residents and I teach people, I make them practice with the patient supine because that's generally how they are. Now, certainly turning them left lateral does improve my images, but with POCUS images, sometimes you're getting what I refer to as a POCUS image where it's not crystal clear. The more often you do it, I think the more you're able to gather information from these images that aren't quite as clear. But I always do preface that if you feel your image quality isn't good enough to answer the clinical question, get more information, call for that formal echo. Say, I'm not sure if this looks normal. I'm going to call in that stat echo because I feel like something is not right here. In addition, I've learned that while I might have difficulty obtaining all 4 images perfectly, there's generally at least one image that I can get when the patient's supine. So for example, if they're supine and intubated, getting that peristernal long and peristernal short is sometimes almost impossible. But a subxiphoid sometimes then comes in very, very clearly. So I also teach the residents to kind of if this is the only image you get, how can you get as much information as possible from that one image? So for example, in the subxiphoid view, I'll teach them to rotate to actually get that short axis view from the subxiphoid view so that you can look more at function. And maybe give them some tips on how to look at the right ventricle. So I might not be able to evaluate the right ventricle like I would like to in an apical 4 chamber. I can still hopefully gather some information that either takes it off my differential or puts it higher at my differential.
Great, thanks.
Well, Rachel, thank you so much. This was really helpful, as is evident by all of the wonderful comments as well. Once again, if anybody would like access to this lecture, please email myself or Elaine Wong, and we will try and get that for you.
Thank you. Give it a second and I need to say anything back. No.